thing to think about is that all organs are not created equal. So in this kind of timeline or scale here, you have small bowel transplants on the left side of things, and then the liver transplant on the right side of things. These do not have the same risk of rejection overall. So small bowel and lung transplants have the highest risk of rejection. So they need more immunosuppression compared to someone who has a kidney or a liver transplant who needs a little bit less. So with that being said, we know that we need different types of immunosuppressants or anti-rejection medications to prevent rejection from happening. We know that there's different factors based off of what type of transplant you received, what other types of past medical history you may have, or other comorbidities. So these are all things that get taken into account when a transplant center is developing protocols and medication strategies to prevent rejection. But we know that there's also a lot of different types of immunosuppressants. So we're going to go through them kind of one by one. And my goal here is not to overwhelm you with all this information, because some of this may not refer to the types of medications that you are currently on or may be on if you are expecting a transplant. But this is just things to think about, things to be aware of, and really just to give you some information that if you are experiencing any of these types of things in terms of side effects or have questions, that these are certain questions that your transplant team can answer for you. So this is a list of all of the different types of immunosuppressants that we have currently on the market for preventing rejection after transplant. What I would like you to really focus on for the purpose of this presentation is the list of medication names on the right-hand side. So while the class of medication is important and kind of shows us how they specifically work, this is not really important for you to really remember, to know. It's helpful to know the names. So things like tacrolimus or mycophenolate, prednisone, those are all the important names to be aware of that could be a part of your regimen. And so we're going to go through these one at a time to really kind of highlight some of the more important factors. So first, the calcineurin inhibitors. These are really the most important and most common post-transplant medications we use. These have shown the best rates of survival and decreased rejection. Now, just because it shows the best, overall data does not mean that it's the best choice for everyone. So if you're not on one of these medications, there's likely a reason for that, and that's okay. There are many reasons why we switch patients off. So this table shows the different types of calcineurin inhibitors that we have. So we have tacrolimus or cyclosporin, with some of the brand names listed there for you. So Prograf being one of the more common brand names of tacrolimus. Envarsus is one of our newer agents. That's the long-lasting once-a-day tacrolimus. And then we have some brand names for cyclosporin as well. The dosing is listed there for you. It's usually either twice a day or once a day for those long-lasting medications like Astigraf or Envarsus. And then monitoring is going to be a super important concept when we talk about these medications. And I have another slide to highlight some of that importance. But we do know that these medications do need to be monitored. And so when we're talking about monitoring, we're talking about getting drug levels tested in your blood when you get lab work done. So we'll talk a little bit about that. And then I have a bolded point there that these medications, really none of them should be cut or crushed or chewed. Really, you should leave the capsule or the tablet as a whole pill when you take it, unless told otherwise. So monitoring calcineurin inhibitors, this is a super important concept after transplant. And it's really vital for us, especially as transplant pharmacists, to make sure that you are in a good spot to prevent rejection. So levels should be drawn before your morning dose, and there's reasons that we do that. So this is just a picture. First, you get your blood test done. So that's going to a lab, LabCorp, Quest, going to your local hospital, wherever you get your labs done. Then you take your Prograf or tacrolimus after that. And this is a picture to kind of show what's going on in your body when we take these medications. So each time you take a dose, you're going to get a level of the medication going into your body. It's going to go through your stomach and your intestines and ultimately get absorbed into your bloodstream. But then your body's going to kind of metabolize that medication and clear it out of the system. And so it's going to start to go down. And each time you take a dose, that happens. What we want to detect when we're checking these levels is the amount in your body or in your blood right before you take your next dose. So that's where it says trough, right at the bottom of kind of that overall curve. And that's really where we're trying to detect how much is in your blood to make sure that at that point you still have a good amount in your blood that's going to help you prevent rejection. And why this is really important is because that tacrolimus and cyclosporin, these medications have a really narrow threshold of where they work, where they also can then, if they're too high or too low, cause either harm if they're too high, or if they're too low, that puts you at risk for rejection. So it's really important that we try to keep you within that green desired level at all times. Now, it's not to say that there are going to be blips. Your levels will fluctuate over time. There's a lot of factors that can impact that. But our goal is to keep you within that green threshold as much as possible throughout your course of transplant. So when we talk about this level of medication in your blood, the goal level that each patient has is really dependent on a lot of different factors. So each person will have really very different goal levels overall. And this can be impacted by the time since you were transplanted, what type of transplant you received. So again, thinking about, lung transplants may need higher levels to prevent rejection, where something like a liver transplant patient may not need as much in their blood at all times. The transplant center itself may have different protocols. So, I practice at the University of Maryland Medical Center. We have specific protocols for each organ that we transplant, but that may be different compared to some other centers, even at, Johns Hopkins, which is right across the street in Baltimore. So it really just depends, and they're all very similar, but there's going to be slight differences depending on where you are transplanted. And then, of course, any other medical condition that you may have can also impact how much we need in your blood. And I'll talk through some of that as we go. But really, the biggest point here is that you're going to have the highest concentration during your first year following transplant. And that's really regardless of what type of organ you receive. And then depends on if you've had any prior rejection, if you're having any side effects, if you've had any infections. Those are all going to kind of drive where we want your goal level to be. So getting into some of the side effects, and this is where I have some pointers as to how we can manage some of these things and really get into things that you can just be aware of. Not every patient will experience these side effects, but it's very good to just be aware of them. This way you can contact your transplant team and we can decide if there's a safe alternative or something that we can do to help you prevent those side effects. So for both of these medications, they can both decrease your magnesium, increase your potassium. So this is why it's always important to get your labs drawn on time. And then if your levels go too high for too long, it actually can start to affect your kidneys. And that may seem pretty crazy to anyone who has received a kidney transplant. We're using these medications to keep your kidney healthy, but it can also harm your kidney. So again, this is just really important to keep a close monitoring of those tacrolimus levels. And that's where we really want to keep you within that green threshold that I talked about. So close monitoring of lab work is really important in this setting. And then we really want to minimize levels that go too high for too long to prevent any of this from happening. Now, splitting it into the individual medication, because there's some slight differences between side effects. Tacrolimus can cause an increase in your blood sugars, so especially important if you've already had a history of diabetes or can develop diabetes after transplant. Can actually cause some hair loss and then even a slight hand tremor where your hands are a little bit shaky. So these are all things that can happen. And then cyclosporin can cause increase in your cholesterol and increase in your blood pressure. So again, if you have high blood pressure even before transplant, that's going to be important to keep a close monitoring of. And then even some hair growth or gum swelling is possible. But really what we want to prevent here is optimizing other medications, or if we need to, we'll need to switch you to a different agent. So if you're having really bad gum swelling on cyclosporin, maybe that's not the best medication for you, and maybe we need to try out tacrolimus. Obviously, we have to do that safely with your transplant team, but these are all things that we consider after transplant to make sure that we're preventing rejection, but also not preventing you side effects that are going to make you not want to take these medications. The other important concept about calcineurin inhibitors like tacrolimus and cyclosporin is that there are a lot of other medications that can interact with these medications. There's too many to even be able to go through for today. So the important point that I want to point out here is that you should always contact your transplant team or coordinator or even your local pharmacist before you start any new medication. So what I mean by that is, let's say you go to your primary care doctor that's outside of the care of your transplant team and they want to start you on a different medication. You should make sure to contact your transplant team or even your local pharmacist just to make sure it's safe. There are a lot of medications that can cause your tacrolimus levels to go really high, which would put you at risk of side effects. There's also a lot of medications that can cause your tacrolimus levels to go really low, which would put you at risk for rejection. So both of these things are important, and we want to make sure that we identify them right away. This is a list of just a few things that have come up, more frequently in the field of transplant, especially the top one, Paxlovid. That's a common medication that's used, especially in the world of COVID now. This can cause your tacrolimus levels to basically skyrocket to the point where we have to hold the drug usually for about a week while you're taking this medication. So if you have a doctor that's prescribing you Paxlovid for COVID symptoms, you should definitely let your transplant team know right away. A common herbal supplement that patients don't even realize could have an impact on your transplant medications and why these are really important to run by your team. Something called St. John's wort that some people will take can really decrease some of your levels and put you at risk for rejection. Grapefruit juice is a common thing that we educate all of our patients about. They really should be avoiding grapefruits and grapefruit juice because of this interaction. And then NSAIDs, so that's your non-steroidal anti-inflammatory drugs like ibuprofen or naproxen, Advil, all of those brand names. Those can also just increase your risk of kidney damage when you're taking it with tacrolimus and cyclosporin. And so why we recommend that all patients avoid these medications completely. So the biggest thing is that you should avoid the bottom three. Paxlovid is safe when done so correctly. But I do want to point out that baby aspirin is okay. A lot of transplant centers will use baby aspirin for a variety of different reasons after transplant, and that is a safe medication to take when you're on one of these medications like tacrolimus or cyclosporin. Switching gears to some of the other classes of medications, that these won't take as long. There's not as much of details that need to be discussed. The calcineurin inhibitors, while they're the most effective medication we have, they also do have a lot of the more challenges with those levels and making sure that everything is safe. These other medications that we'll go through have a little less of that specific monitoring that we'll talk about. So antiproliferatives, so these are the second most common, and these are medications like mycophenolate or azathioprine. Mycophenolate has two different brands, Cellcept and Myfortic, and it really just depends on where you're transplanted, the different types of insurance that you have, and what the practice is at your center of which one is used, but both are very effective. They're both twice daily medications. The only difference being is that Myfortic is considered more of a slow release medication. We do not need to monitor anything for these medications in terms of levels of the drug, but there are some special considerations. So for mycophenolate, it is contraindicated in pregnant women. So this is why there's some specific criteria that we'll talk about on another slide when using this medication. And then mycophenolate, again, should not be crushed, cut, or chewed. You should take the tablet whole always. So I mentioned the risk in pregnant women. Mycophenolate has shown an increase in the risk of birth defects and pregnancy loss in the first trimester. So this is really why it's very, very important that we prevent and plan. So pregnancy after transplant is a very valid interest of many patients. We just have to do it safely. So first, we should always have a plan. Making sure that we have adequate birth control on board, talking with our transplant team as to when we should safely do this. If anyone is to become pregnant at any point after transplant while on mycophenolate, they should let their transplant team know right away. There's things that we have to do very quickly to be able to get you off of that medication and make it safe for both you and the baby. Some side effects to be aware of these medications. So both of them can cause, and this is mycophenolate and azathioprine, can cause low white blood cells and low platelets. So these are both labs that we check very regularly after someone gets a transplant. And really, if this does happen, we may need to decrease your dose because this can put you at risk of infection and bleeding. So we want to make sure that these do not happen and they are controlled appropriately. In terms of the differences between the two medications, mycophenolate, the biggest side effect that we educate our patients about is diarrhea, nausea, and even some vomiting. And then azathioprine can cause some stomach upset, not to the same extent as mycophenolate, and also can cause some hair loss. For mycophenolate specifically, if you are experiencing any of these side effects, there's a couple options that we have. So if you're on Cellcept as the brand name, there's a thought that we can change you to Myfortic, which again is that slow release medication. And if you look at the graph to the right, that red box or red line, the sustained release is showing you what Myfortic is doing compared to Cellcept. So you're getting kind of less of that initial peak in your body, and then it slowly is metabolized and removed from your body. And so there's some thoughts that may help prevent some of the diarrhea that could happen. Unfortunately, that's not the case necessarily for everyone. It does depend. Every patient is a little bit different of how they tolerate these medications. And insurance, unfortunately, sometimes does dictate which one can be covered. So it does sometimes make a challenge for us as a transplant team. We can also split the doses and take it a little bit more frequently. And so what I mean by that is if you're taking, let's say, 360 milligrams, which is one tablet twice a day, we can give you a smaller tablet and you can take 180 milligrams, which is half the dose, and you just need to take it 4 times a day instead. And that can help with some of those GI symptoms sometimes as well. We can decrease the dose. We can also change to azathioprine. But again, we have to do this safely with our transplant team. And then azathioprine, if we have any of these side effects, we can either take it with food, we can decrease the dose, again, as tolerated. And then we'll talk a little bit about steroids. So steroids are a very common part of the medication regimen after transplant. It's one of the original medications, as I mentioned in that first graph, showing that they were, really used in the 1960s and have been continually used since. They work by really impacting a lot of different areas of our immune system. And these are medications like prednisone, prednisolone, or even methylprednisolone. These are all common steroids that are used. We typically give them as a once-a-day medication, typically higher doses initially after your transplant, and then over time we can safely decrease them and maybe even stop them altogether. We do not need to monitor anything in terms of drug levels for these medications. And these are a little bit easier. You can cut them, you can crush them if needed. So a little bit easier to take if you have trouble with the pills. The nice part about prednisone is typically it's a smaller tablet, so usually a little bit easier to take. And then if you do have some stomach upset with the steroids, you can take it with food as well. Now, with every steroid, although it's got some really great, effects of preventing rejection after transplant, there are some side effects just to be aware of. Most patients generally hate being on steroids. If they can avoid it, they'd rather be off of them. We always know that as a transplant team, and we try to get them off as soon as possible. But we break this down into what's called short-term side effects and long-term side effects, depending on kind of how long you're on them. So initially, when we give higher doses, we may see some changes in your blood pressure, your sugars, may have a little trouble sleeping, may feel like a little bit more agitated than normal, may feel a little bit more hungry than normal. These are all very common, early after transplant, but then should go away as the dose goes down. If we have these side effects, we may need to take some fluid off of you. With some other medications, we may need to give you a little insulin to just prevent your sugars from going too high. We may need to give you some other or optimize some of your other medications for your blood pressure or even for sleep. If we are able to, we can reduce the dose of the steroid. And we'll give you some acid-reducing medications such as famotidine or Pepcid, or even Protonix, which is a common medication patients will go on after transplant. And now in the long term, if you need to stay on these for an extended duration, depending on, again, your transplant center protocol, we may see changes in your cholesterol, can change your growth with bone suppression, and then even potentially weight gain due to fluid as well. So again, we may need to start you on a cholesterol lowering medication. It's good to take some vitamin D and calcium to make sure your bones are nice and healthy while you're on the steroid. And then if we need to or are able to, we'll reduce the dose or stop the medication altogether. A couple other classes of medications that we'll talk about before we switch gears a little bit are the mTOR inhibitors. So really the biggest area where these are used are to decrease the kidney effects that we talked about with your calcineurin inhibitor. So if patients are having experiencing some kidney dysfunction, so maybe their serum creatinine is going up a little bit, and we want to prevent that from happening or getting worse, we may switch you over to one of these medications to help prevent that. That's just one example of where they're used. There's a lot of kind of nuances about these medications that, we do use them in certain areas, but that's kind of one of the bigger ones that I wanted to point out. So these are your sirolimus or everolimus with the brand names listed there for you. Sirolimus is a once-a-day medication, where everolimus is a twice-a-day medication. And these are very similar to the monitoring that's needed with your calcineurin inhibitors, that we're able to and need to check levels of the medication in your blood. And then again, they should not be cut, crushed, or chewed. So as I mentioned, this is a very similar slide with all of the same concepts. The goal of our mTOR inhibitors really will depend on, when you were transplanted, what type of transplant you received, where you were, other medications that you may be using at the same time to prevent rejection, and then potentially any other medical conditions. We want to detect the level of the medication in the blood right before you take your next dose. And we really want to keep this within that desired level, which is the green kind of bar there, as much as possible. Similarly, as well with the calcineurin inhibitors, the mTOR inhibitors also have a lot of drug interactions that are out there. So again, reiterating that point, to just always contact your transplant team if you start any new medication while you're on these medications as well. And then in terms of the side effects, I think this is really where we struggle as a transplant team, is we know that there are certain patients that would benefit from being on an mTOR inhibitor like sirolimus or everolimus. But there are some side effects to these medications that can happen, and some patients just really don't tolerate these medications. Everyone is different, so it's great that if you are able to tolerate them and can continue, that's obviously awesome, but there are certain patients that really just don't. So they can increase your cholesterol, they can impair your wound healing. So, obviously if you're planning to get any type of surgery or know of any surgery coming up, after transplant, these are reasons to contact your transplant team, because we want to make sure that you're able to heal appropriately. Mouth sores can be very painful on these medications. Swelling, edema can happen, and then some changes in some of your labs as well, like we talked about with some of the others. So there are definitely, things that we have to just be mindful of. You may need some other medications for cholesterol. We may need to decrease the dose or even the goal level of that, green level that we're shooting for. We sometimes just limit the use in certain patients if we know that they're not going to tolerate them. And then if, of course, if you're on one of these medications and you feel like you're not tolerating them, if able to, we will try to switch you to something else. And then lastly, we'll talk about the co-stimulation blocker, and this is belatacept. This is one of the newest immunosuppressant medications that we have on the market today. Similar to the mTOR inhibitors like sirolimus and everolimus, this is used to really decrease some of the kidney effects that we see on the calcineurin inhibitors. The kind of big change with this medication that was really interesting when it came to market was that this is actually an IV infusion. So you don't have to take this by mouth. And once you're kind of through the initial, phase of taking it, it's a once a month infusion. So definitely can be really, convenient for some patients to only have to take once a month. And this can be done either at home through an infusion company or even at an infusion center where you go sit there and actually get the medication there. Again, this is not for everyone. Insurance definitely has a big say in, who's covered to even get this medication. There's, very specific patients that we use this in, at least at our center, in terms of kidney transplant patients. Many other transplants do not have the approval for this. So it's really only used in kidneys as of right now. There is an increased risk of certain types of cancers, but adherence can also be, improved by only needing a monthly infusion versus having to take something once or twice a day. So there definitely is some benefits to this medication, belatacept, but also some challenges as well. So kind of final reminders as we finish up the immunosuppression section here is, these medications have really increased the life of the organ and our patients, which is obviously the end goal is we really want to keep these organs and our patients as healthy as possible for as long as possible. If you're experiencing any side effects or you feel like you're not sure if it's maybe from these medications, talk with your team. You have most likely a coordinator that you're able to call. They can contact, at least at our center, we have a direct way that these coordinators can contact our pharmacy team, contact your surgeons, your whole team. We want to help you as much as possible to, obviously we want to keep your organ as healthy as possible, but we want to make sure that we're also preventing you any side effects as well. And then really the biggest thing at the bottom there is never stop taking your medications on your own. This should always be a conversation with your transplant team. While we don't always need the same amount of immunosuppression after 5-10 years of transplant, we still always usually need something. And so you should just always contact your transplant team before you do anything. All right, so just going to check my time, make sure we're okay here. So I have about 15 or so minutes. So I'm going to go a little bit quicker through some of this stuff that I wanted to spend the most time on. Obviously, this is recorded and my slides will be accessible. And I'm happy to share them even offline if anyone is interested. But we'll talk through some strategies to take all your medications on time. There's a lot of different tools out there that you can use. I'm just going to name some of the ones that we have at our disposal. So first, a medication list, whether it's a printed copy, whether it's a handwritten one, anything to help you kind of organize your transplant medications is really important, as we know that there are a lot of them that are started after transplant, and it can be very overwhelming at first. And we want to, make this as easy as possible for you as you transition really from, the early phases of transplant. There's some automatic reminders on your phone that you can work with your pharmacy about. Setting alarms to make sure that you're taking your medications on time can be really helpful, especially in the beginning. Automatic refills at your pharmacy. And then even some electronic med lists are available as well now through your cell phone. Obviously, depending on how well you are with technology. I know me personally, everyone at my work makes fun of me because I am the worst with technology. So this would not be something I would do. I would probably be going to the paper. But everyone is different, and you just need to figure out what is going to work best for you. Some other things, this is an example of a pill box that we give our patients at the University of Maryland. There are a lot of different examples of this out there that you can certainly buy or get through your local pharmacies. Definitely recommend using a pill box, setting it up each week. That can really help you just stay organized and not have to remember all the different bottles. Depending on how much your medications are changing over time, there's certain pharmacies that do kind of a pre-filled pill box. So they will actually send you your medications already filled with the week. That is not usually recommended early after transplant since a lot of things may change. But over time, if this is something that you're interested in, you can definitely talk to your pharmacy about. And then there's even pill boxes now that have kind of you fill them normally as you would, but then they even have little reminders set within the pill box itself that will go off. And these can definitely be helpful if you're having trouble remembering to take your medications. But the biggest thing that we recommend is just take an active role. We know this is overwhelming. We know there are a lot of medications This can be very confusing. There's a lot of different, names, and they all, usually don't even sound like English when you're first learning the medication names. Even, I went to pharmacy school for 4 years and it's still hard to pronounce some of these. So we definitely just want you to, have a good idea of at least some of the medications that you're on and general doses. And just to be aware of the side effects. This way, you can be your biggest advocate to your transplant team, is just knowing kind of your own body, your own kind of day to day, to make sure that you're advocating for yourself. And then I have a list of questions of things to just ask yourself and ask your team. So, do I take this medication with or without food? What if I forget to take a dose? What happens if I run out of medication? What if I can't afford my medications? Obviously, that's super important as well. And then is there certain times that I have to take them? So I have some general information here in terms of, each of these questions. So the food concept, it really just depends. Some medications need a lot of food in your stomach to be able to be absorbed. Some don't need anything and actually are worse if you have food. So really, it's hard to go through each individual medication, but the biggest thing is just ask your pharmacy team, ask your doctors if there's a specific way that you should be taking it. And then if an empty stomach is needed, you should take it about an hour before you eat or 2 hours after, just to make sure that, you don't have too much in your stomach. But again, just always ask your pharmacist. If you forget to take a dose, it really just depends on how often you take the medication. The biggest rule there at the bottom that's bolded is you should just never double up. If you forget to take the medication, that's, a twice a day medication. If it's within a 4 to 6 hour window is what we usually say, then it's okay to take that dose. Otherwise, you should just wait until your next regular scheduled dose and then take it at that point. If it's a once a day medication and you forget, you can take it late and it doesn't matter as much, but just really the biggest thing is just never double up. If you run out of medication, I think the biggest thing here is you should just contact your transplant team and coordinator right away. But the biggest thing that we want to recommend is to try to avoid this as much as possible. Requesting refills in advance, using those automatic refills, alarms to make sure that at that time of the month. Obviously insurance will have a say in how quickly you can refill a medication, but there's usually a little bit of a window before, you're going to be out of your medications. But making sure you're planning in advance to avoid running out of a medication and then contacting your team, ahead of time if you have any issues. And then, of course, if the cost of your medications is significantly impacting your ability to take them, talk to your team. Our pharmacy team and social work team can help. There's a lot of assistance programs that are out there. There's copay cards. There's sometimes grants to help pay for medications. We may be able to switch you to a cheaper alternative. There's really just a lot of different options out there that can help you in terms of, the cost of medications, since we know that these are not cheap all the time. All right, so I have a few more minutes before I want to make sure I leave plenty of time for questions as well. So I'll go through some of these last few slides about insurance. I'll go through fairly quickly, again, just to make sure I have time. So this slide shows that there's a lot of different types of insurances out there. I listed as many as that, come up as a common list. I was going to focus more on the Medicare, Medicaid side of things. And again, there's a lot of information in here. And I'll highlight one of the main slides that, has some links for you to use if you are interested in learning more. Medicare, we know, is a federal health insurance. It's available for people that are 65 or older, unless you have some other conditions or disabilities. So conditions like end-stage renal disease, if you have required dialysis or a transplant as well. And then that open enrollment period is definitely very important to be able to enroll in these. This is an example of what your card would look like, showing that you have Medicare Part A and B, which I have a slide about, and then the date that your coverage is effective. So you may have seen something like this. And then really the biggest point is that there's a lot of different intricacies about Medicare in terms of A, B, C, and D. Each of them kind of covers you under a different aspect of your care. For the purposes of my talk, and since I'm a pharmacist, of course, I'm going to focus a little bit more on Medicare Part D, which is your prescription drug plan. This is optional, but it is offered to everyone. So you don't have to have a Medicare Part D plan just because you have Medicare, but you will have additional coverage if you have a Part D plan. The different types of monthly premiums will depend on, your income. It can change each year, depend on the plan. So all that really depends. But I think this slide is really important. If you want to, you'll have access to this. You can join a plan through the link of that Medicare drug coverage. There's paper enrollment forms. There's a number that you can call. But I think the biggest point is that you really, before you make any decision about a plan that you're going to be looking at, you should really try to look through that second link and learn how your prescription drug coverage works with other drug coverage that you may have. So whether this is a private plan or a secondary plan, a lot of this can be impacted if you sign up for a Medicare before signing up for any specific plan. This is a slide just showing that each Part D plan will have a different kind of formulary of medications. And really what that means is a different list of medications that they will approve at different costs. So there's different tiers, with tier 1 kind of having your lowest copayment at the bottom there of that triangle. And then tier 4 being kind of your specialty medications that may have a little bit higher cost overall. But it's good to just understand what your plan offers before signing up. And then, of course, the donut hole is a very big factor in our transplant care and our transplant medications. And this really just changes the coverage that you may have in terms of how much your out-of-pocket is going to be for the medications. But this is really good to just have an understanding of, to just be aware when you're in these different phases of your insurance that you may have different costs. I'm going to skip the Medicaid slide just because I want to make sure I don't have spent programs. There's different state specialty programs depending on where you live. And again, I have the links in there for you if you have any specific interest in going through and looking at that information a little bit more. And then lastly, I just have a slide about our patient assistance. I mentioned that there's different programs that are available that either provide low or free drugs to patients depending on their other coverage. Just check with your team to make sure that we're exploring all possible avenues for you. And same thing with copay cards. There's a lot of cards that are out there to help. These are not eligible for Medicare patients to decrease cost. So lastly, just our key points to wrap up, and then I'm happy to answer any questions. A successful transplant, while there's a lot of other factors that go into it, it's highly dependent on you as well, taking that active role, knowing your medications, advocating for yourself, and making sure that your transplant team can help you with anything that's possible. Immunosuppressant medications have really increased the life of all organ transplants and our patients, which is awesome to see, and obviously the goal to continue. Talk with your doctor or pharmacist about any side effects you're having, know your medications, and ask questions. Never feel like you're asking a silly question. Each person is very different and has different side effects, and we want to make sure we, are available to answer those questions. Always take your medications as prescribed. This is going to give you the best, overall life out of your organ and for yourself as well. And then always ask your transplant team if you have any questions about, really anything, but of course, insurance as well. And then I'm happy to answer any questions. I know I went a little bit fast through the end of that. I apologize, but wanted to make sure I left some time to answer any questions. And I'm going to stop sharing my screen so I can pull up the chat as well.
So, Ian, that's great. You'll send me your slides and we'll have them on our website for anyone to go back in and look at something that's more detailed. But you do have a lot of questions in the chat if you want to start going through those, please.
Sure, absolutely. I'll start at the top. The first question that's in the chat here is, why is race a factor in rejection? That's a very good question. That's something that's been shown really just through the different studies that have been done across different transplant centers and, not only just in the US, but in other countries. And it's been shown that specifically African Americans have an increased risk of rejection really at baseline. Some of that is also to do with the way that certain medications are metabolized. So African American patients can actually metabolize the tacrolimus and cyclosporin quicker than non-African American patients. And that can lead to just lower overall kind of exposure or drug levels, and could impact the overall rates of rejection as well. So that's a newer kind of concept, and so you may just need higher doses of those medications. But it really just goes down to some of the data that's been shown. The second, please mention importance of taking our meds. Of course, I 100% agree with that statement. As as I mentioned, it's super important to take your medications every day on time, as close to possible, as close as possible to the scheduled time. Even just a couple days worth of missed medications can put you at risk for rejection. So it's super important to take them as scheduled. What is the correlation between using the AlloSure blood test and heart biopsy? So now we're getting into some very specific questions. AlloSure, to keep it simple, is a blood test that's sent that detects the amount of donor DNA in the recipient's blood. So because you have the donor's organ, that is going to shed some potential DNA into your blood, into the recipient. And if that is going up, that means that maybe there's some damage to that organ, because now that organ is kind of spilling some of the DNA out into the blood. And there's a lot of different things that can cause that to happen, but rejection is one of them specifically. So if you're, in this example of this question, you're saying heart biopsy, if we're doing a heart biopsy, and we show that there's some rejection on the biopsy, that could mean that the AlloSure blood test is also elevated at the same time. Now, what we usually do at our transplant centers, or most transplant centers, is we try to use these blood tests before we need to get a biopsy. So the way, or the thought there is that by using the blood tests first, we may be able to avoid getting a biopsy altogether, because we can see if your organ is working properly ahead of time. There's a lot more intricacies to it. Insurance has a big impact on this, and costs. So definitely talk to your transplant team more about AlloSure. If you're not getting AlloSures tested, don't worry about it. That's not something that we do on every patient. But that's kind of the basic concept of those tests. And those are, fairly new over the last, 5 to 10 years or so. Next question I see, please explain the difference between Protonix and omeprazole. I was initially placed on omeprazole, but then switched to Protonix by my new healthcare team. Honestly, every patient's really just different. Some just prefer one versus another in terms of how it's working for them. There's really no major difference in either one of them. They're both the same class of medications. Depending on your insurance, one may be cheaper than the other. So that can sometimes be a factor. But as long as one of them is working for you, there's really, from our perspective, we do not, usually have a say as to which one we want you on. Either one is perfectly fine, and both have the same overall efficacy and safety. Good morning. Information is helpful. I appreciate that. I'm glad to hear that it's helpful for everyone. Importance of telling your team about vitamins or supplements you want to take. I very much agree with that statement. We didn't talk a lot about different herbal supplements and different vitamins. While most vitamins are safe to take, there are a lot of herbal supplements out there that can interact with your medications and may not be safe for you in a transplant patient. Since you now are on anti-rejection medications and are immunosuppressed, a lot of these medications are not as regulated as our FDA approved medications. And so we typically shy away as pharmacists telling you to take a lot of these herbal supplements. So definitely run it by your team before you start taking anything, to make sure that it's safe for you after transplant. When is the best time to get vaccines when you're immunosuppressed? That is a very good question, and probably a whole lecture on its own. vaccines are definitely safe after transplant, but there is a general recommendation to wait about 3 to 6 months after transplant to get your vaccines. The only caveat to that is that if you're transplanted, let's say right around this time, as we're kind of entering in the peak of flu season and probably COVID season, those recommendations are to get the flu vaccine usually after the first 3 to 4 weeks of transplant. We want to make sure, the reason for that is we want to make sure that you get the best overall effect by the vaccine by building an immune response to these different viruses. But if we're doing it too early after transplant, your body's not going to be able to build that same response to the vaccine. So that the goal is to wait as long as possible, if we can safely do that. But at the same time, during the peak of flu season, the risk of benefit to you is probably better to just get the vaccine a little bit earlier. But definitely talk to your team, talk to your local pharmacist, and they can help guide you a little bit more as well. That's a very nice comment. I told my sister that you were presenting, and she said you are one of the best at what you do. I'm not sure the name. I think is Kim Barnett is who you're referring to, who I work with. So I definitely appreciate that from her. Miss Barnett, I always call her Miss Kim, still to this day. She was one of the first people that helped onboard me at Maryland when I was a first year resident 7.5 years ago. So we've kept in touch, and it's very nice that she gets to kind of still see us there, as I've been there for 7.5 years. So tell her I said hello and thank you. Will taking your twice a day pill, say 9 a.m. or 9 p.m., about half hour before or half hour after, make a difference in your cyclosporin levels? No, it's a very good question. We always try to say as close to 12 hours as possible, but that is in the book answer, as you want to take it 12 hours apart. In real life, I always tell my patients that I know it would be basically impossible for me to do something exactly at 12 hours. So if you take it a half hour early or a half hour late, in the grand scheme of things, it's not going to impact your levels that much. Even really an hour or two is better than not taking it at all. That's what I always tell people. So fit it to your schedule as best you can. But at the end of the day, it's very much okay that things are going to fluctuate. Does belatacept include steroids and have some of those steroid side effects? Belatacept, typically, if we do switch, at least at our center, if we're switching our patients to belatacept, they will typically go on prednisone as well, just to prevent rejection from happening. Again, every transplant center may be slightly different, but you will likely be on a steroid at the same time as belatacept, which could then lead to some of those side effects I mentioned. How bad is the acne risk on everolimus? Is it reversible? It really depends. I think every patient's slightly different. Obviously, if you've had a history of acne, probably going to increase your risk of developing, more on everolimus. But it really just depends. It's usually from depending on how your levels are. So if they're running too high, that may also be impacting it. I would say if that you're on everolimus and it starts to happen, just talk to your team. In terms of reversible, if you stop taking it 100%, it will go away. But there's nothing that we necessarily would be able to do, if you continue on everolimus specifically. And I'll try to get through a couple more of these questions before the time's up. Second time watching this presentation, and your encouragement in patients playing an active role, but understanding medications and dosing really encouraged me to take charge of it. My weekly medicine. It helped me take the responsibility of filling my pill packs for the week. It is the only way to learn and empower yourself. Thank you for your awesome presentation. I definitely appreciate that. This is what makes our job that much better. And hearing stories like that. And that's why I love doing these presentations. We do this job. I love doing my job. I love being able to talk to patients and, try to empower them and encourage them. There's only certain things that we can do while you guys are in the hospital or when we see you specifically in the clinic, and I'm sure if you ask every pharmacist or provider you see, we would love to help you even more if it was possible. But, by empowering you and giving you the tools to be successful on your own is really the most important thing we can do. So I'm glad it's helping, and I'm happy to give this presentation 100 times if it means that everybody feels empowered to do so. I thought anti-rejection drugs are free to transplant patients. It just depends. If you have Medicare Part B, that is where your anti-rejection medications are actually coming through. And typically they are free for most Medicare and even Medicaid patients. But for other private insurances and other insurances, it really just depends. So copays can really change depending on the type of insurance that you have. And I have a couple more questions. I'll try to get through them. I've had 3 kidney transplants over the past 40 years. My most recent one was 3.5 years ago. Since that transplant, I am sweating profusely. I'm on Tacrolimus, Cellcept, and prednisone. Is sweating a side effect of those medications? Sweating, that can be a sign of just maybe your tacrolimus levels are slightly elevated. It really just depends. My recommendation, without knowing kind of the full history, would be to talk to your transplant team about it and see if there's anything else that they want to, maybe send other labs and make sure that there's nothing else going on. How common is a combined tacrolimus and everolimus protocol? That's very common. Usually that's what we will do is it will take the myfortic away if they're not tolerating that class of medications, and then trial them on a combination of tacrolimus and either everolimus or sirolimus. So very common. We use that combo all the time. What tier drugs are tacrolimus and Cellcept? Really depends on the insurance. Usually on the lower end of the tiers at this point, because we have generic versions of the drug, they're not as expensive. So typically should be in your lower tier, not necessarily your tier 4 specialized medications. And then I'm highly sensitized with antibodies. Will this dramatically affect my drug needs? Yes, typically if you have a high sensitization with antibodies, that means that you are more likely to react or reject organs in general. So we usually will do slightly different protocols and keep you on more immunosuppression overall to just make sure that you're safely immunosuppressed. But again, your transplant team will decide that. And then, do you ever stop taking Valcyte or valganciclovir? Typically, yes, depending on the protocol and the type of organ transplant you received. Usually, a maximum of about a year, if that's the case, depending on the type of organ. But sometimes even only 3 to 6 months. So it really just depends on your transplant center. If you feel like you're beyond those times and you're still on it, it's probably good to talk to your transplant team to see if it's safe for you to stop it. Can most of the medications and supplements be taken simultaneously twice a day? Yep, absolutely. If you're comfortable taking ICBID per fistful, if you can take 10 medications at a time, most of them are perfectly fine. We will usually specify if it needs to be separated. Best presentation yet. I'm really happy to hear that. That's awesome. And then last one here, do you have any recommendations on better insurance carriers other than UHC? They no longer cover. Yeah, this is a newer change. United Healthcare has removed certain, or I guess Hopkins has no longer is accepting United Healthcare. That would be something, if you were transplanted at Johns Hopkins, I would suggest talking to your transplant team, looking through the available insurances, especially if it's Medicare or Medicaid, see what's going to be the best for you in terms of what Hopkins covers. Unfortunately, I can't really answer that question, for you specifically. I think it's best to just look through and talk to your team, and see which one's going to make the most sense for you based off of your specific situation. And your medications. And then excellent presentation. I really appreciate it. And thanks for all the questions. This is great. Obviously, I'm sure you guys could have plenty more questions, and each person is very specific. But I'm happy to answer all those, and I appreciate all of your time today. And I'm glad everyone enjoyed the medication presentation.
Ian, this was awesome, and I think it was so special that you had that ringer in there with Corey Barnett with his sister giving you high praise. It was just really kind of funny that happened. And you also got kudos from Mike and Linda, who joined us from Canada, and they said happy Thanksgiving and happy Columbus Day. If
Awesome.
Yeah, if from Canada. Thank you very much, Mike and Linda. If anyone does have a question, I know this is such a detailed topic. You can send them to us at Trio Maryland at Gmail. We'll pass them on to Ian and he'll get them back to you at his convenience. And
Absolutely.
thank you again. Again, just so much great information, and you do present it so it's easy for us lay people to understand it. But
Absolutely. Well, I'm happy to have been here again, and definitely looking forward to the next opportunity to present a trio. But definitely let me know if you have any questions. I'm happy to help at any time.
And Ian, thank you again from me personally. It was great to see your family and see that it's growing.
and
Uh, and
congratulations.
congratulations. I want to
Thank
thank
you.
everybody else for attending today. We love seeing your smiling faces on the weekend. Don't forget to check out our website at www.triomaryland.org. All of our past meetings are posted to our YouTube channel for your convenience. Check out our events page on the website for advance notices for future meetings. And last but not least, have a great weekend and enjoy the sunshine.
Yeah. Good to see you all.
Good to see everyone. See you next meeting.
Bye bye. Thanks again, Ian. Have a great
Yeah.
weekend.